Hello friends, welcome to my YouTube channel. Today we are going to study the remaining part of ortho notes, starting with osteomyelitis. The term osteomyelitis was coined by Nelaton. Most common cause of osteomyelitis is Staphylococcus aureus. Pathogenesis is most common route for osteomyelitis is through bloodstream, that is hematogenous route. It mainly affects skeleton, that is appendicular skeleton more than axial skeleton. So this appendicular skeleton, it mainly affects the femur more than tibia. That is femur mainly metaphysis of the distal femur gets affected more than the proximal femur. Most common bone involved in osteomyelitis overall is metaphysis of distal femur. In case of infants or children also, most common bone involved in osteomyelitis is metaphysis of distal femur. But in case of adults, the most common bone involved in osteomyelitis is vertebral body. Waldo-Gel classification. Waldo-Gel classification is based on duration of symptoms for osteomyelitis, that is acute osteomyelitis is seen less than 2 weeks. In between 2 to 4 weeks, this is known as subacute osteomyelitis, and if the patient presents for more than 4 weeks of osteomyelitis, it is known as chronic osteomyelitis. Most common complication of acute osteomyelitis is chronic osteomyelitis. Here the pathogenic hallmark for chronic osteomyelitis is sequestrum. What is sequestrum? It is a dead, radiodense, ischemic, necrotic, non-viable piece of bone. The sequestrum separates the dead bone from underlying viable healthy parent bone, and also this is surrounded by reactive immature subperiosteal new bone, that is involucrum. There is two surface, that is rough surface as well as smooth surface, and the sequestrum never bleeds, and under microscopy there is no Haversian canal present, and also the sequestrum floats in pus and sinks in water. Pathogenic hallmark for acute osteomyelitis is abscess, which is mainly due to Staphylococcus aureus, and in this lesion we can see pus as well as necrotic bone debris. Next is types of sequestrum. Types of sequestrum includes tubular, ring, conical or annular, ivory, feathery, sand, rice green type, black or cork type, coralliform, kissing type, Bombay type. So, tubular sequestrum is seen in pyogenic osteomyelitis. Ring sequestrum is seen in amputation stump and also around the insertion site of Steinman's pin. Conical or annular sequestrum is seen in amputation stump. Ivory sequestrum is seen in syphilis. Feathery sequestrum is seen in intracavitary TB more than syphilis. Fine sand sequestrum is seen in viral osteomyelitis. Coarse sand sequestrum is seen in extracavitary TB. Rice grain sequestrum is seen in TB. Black or cork type sequestrum is seen in actinomyces or fungal osteomyelitis. Coralliform sequestrum is seen in Perthes disease. Kissing sequestrum is seen in paradiscal TB spine. Bombay sequestrum is seen in H2S inhalation. Management of acute osteomyelitis is if the patient is a young child or of rural background, or if the patient is having rubor, calor, dolor or tumor for 48 to 72 hours in knee, we should examine blood counts, that is CBC, ESR as well as C-reactive protein, and we can see total leukocyte count will be increased, neutrophils will be increased, ESR will be elevated, CRP will be positive. And next we should do blood culture. So in case of osteomyelitis, that is acute osteomyelitis, blood culture will be positive in 50% of the patients. That is, if the blood culture is positive, we should do gram staining as well as antibiogram. This gram staining and antibiogram should be done more than 48 to 72 hours. Next thing we should check is serum procalcitonin level. It will be more than 0.4 nanogram per milliliter. Serum calcitonin level is the sensitive or specific marker for osteomyelitis. For osteomyelitis, that is for acute osteomyelitis, PRICE is the code for remembering. That is, the management mainly includes P for pain relief by using NSAIDs, R for rest, I for immobilization by using splints, C for cold packs, E for elevation. So PRICE, pain relief, rest, immobilization, cold pack as well as elevation. And also broad spectrum IV antibiotics should be used. This is the empirical therapy. First X-ray sign or the earliest X-ray sign for osteomyelitis is soft tissue shadow or lucency will be seen within 48 hours. Second X-ray sign or classical X-ray sign is periosteal reaction or new bone formation for 7 to 10 days. MRI is the investigation of choice for diagnosis of acute osteomyelitis. So, less than or equal to 24 hours, we can see marrow edema. Iridium 111 labeled leukocyte scan or gallium 67 scan or technetium 99M MDP scan, these all should be done. Management of chronic osteomyelitis is patient presence with sinus as well as sequestrum. So the clinical hallmark for chronic osteomyelitis is sinus, and the pathological hallmark for chronic osteomyelitis is sequestrum. Treatment of choice for chronic osteomyelitis is sinogram, sinus tract exploration, sequestrectomy, suturation, curettage, bone grafting, debridement, sinus tract excision. So, speaking about the bone grafting, here the antibiotic laden bone cement bead is placed. Next is about the curettage. When curettage is done, punctate bleeding spots are present intraoperatively. This is known as paprika sign. And next is sinus tract excision. This sinus tract excision for chronic osteomyelitis is done to prevent the recurrence and also to prevent squamous cell carcinoma of the tract. This squamous cell carcinoma is a delayed or rare complication. Post-operatively, drain should be placed, skin traction should be done, IV antibiotics for 6 weeks and oral antibiotics for 6 weeks should be given. Variants of osteomyelitis are Brody's abscess as well as Garrus sclerosing osteomyelitis. Brody's abscess is a subacute osteomyelitis. Most common bone affected is tibia. Here microbe gets entrapped in fibrous tissue proliferation. Immunity is more than virulence. Pus will be present. Pain will be a dull, aching, deep pain. Sinus and sequestrum is not present. Management is curettage, bone grafting as well as antibiotic cover. This Brody's abscess is seen in adults. Next is Garrus sclerosing osteomyelitis. It is a long-standing chronic osteomyelitis. Bone mainly affected is mandible more than tibia. Here, excess periosteal reaction by an extremely sensitive periosteum is seen in response to low-grade anaerobe. Pus is not present here, swelling will be present, sinus and sequestrum not present. Management is antibiotics and also NSAIDs should be given. This Garrus sclerosing osteomyelitis is seen in children. Next topic is septic arthritis. Septic arthritis is a surgical emergency case. Etiology of septic arthritis is most common cause of septic arthritis overall is Staphylococcus aureus. In sexually active age group, it is due to gonococcus. Most common route of septic arthritis is through blood, that is hematogenous route. Most common joint affected is knee joint more than hip joint. Staphylococcus aureus releases proteolytic enzymes, that is degradative proteolytic enzymes like elastase, collagenase, aggrecanase, gelatinase and also matrix metalloproteinase. These all destroy the articular cartilage within 2 to 8 hours. Articular cartilage is an avascular, aneural, alymphatic type 2 collagen which is devoid of perichondrium. And when the articular cartilage destroyed within 2 to 8 hours, when this gets degenerated, it never regenerates. So pathological fusion of joint happens and the end result is bony ankylosis. Clinical spectrum of septic arthritis is like patient will be a child and of rural background. Patient will be having an acute onset, severity will be increased, critically ill. Patient will be presenting with septicemia, chills, rigor, and the other thing is rubor, dolor, cala, tumor, functiolatio. These all will be present. Earliest or the first symptom is pain. There will be antalgic or limping pain, restriction of movements can't or shouldn't be checked. The attitude of deformity is Faber, that is F for flexion, AB for abduction, ER for external rotation. Faber, that is flexion, abduction, and external rotation, is the most comfortable position of hip, and the capsular volume will be maximum here. Management of septic arthritis is blood counts should be checked, that is CBC, ESR, CRP should be checked. Here neutrophils will be increased, total leukocytes will be increased, ESR will be elevated, C reactive protein will be present. Next step is USG guided aspiration. This is done for therapeutic purpose, not for diagnostic purpose. And the best step is arthrotomy, which consists of surgical irrigation and also debridement of joint. This is done via wide incision and exposure through a lavage. Post-operatively, IV antibiotics and also skin traction and drain should be put. Next topic is gonococcal septic arthritis. This is not a surgical emergency case. This responds to penicillin or cephalosporin. The most common joint affected here is knee. Next is Tom Smith arthritis. Tom Smith arthritis is known as septic arthritis of infancy. Most common joint affected here is hip. It spreads mainly due to umbilical sepsis. Since head is entirely cartilaginous, it gets completely absorbed. So there is a poor outcome here. TB is the most common cause of monoarthritis in children. Next are some terms. So, starting with arthroplasty. Arthroplasty is the surgical joint replacement. Arthrodesis is surgical joint fusion. Arthroscopy is minimally invasive surgery, both diagnostic as well as therapeutic. Next is arthrotomy. Arthrotomy is the surgical incision and drainage of joint via wide excision. Arthrocentesis is surgical aspiration of joint. Next topic is sac foot. Sac foot means SACH. Sac means solid angle cushioned heel. So this here the we use lower limb prosthesis, that is base of the lower limb prosthesis, which is an expensive raw material, and it costs about 40,000 to 50,000 USD. It is not cosmetic. No barefoot walking here. Compulsory shoe wear is there. Squatting not possible. Solid keel of metal and wood is there. Plantar or dorsiflexion not possible. Inversion or eversion not possible. Irregular surface walking not possible. Next is about Jaipur foot. Jaipur foot is a base of lower limb prosthesis. It is of cheap material, 40 to 50 NSD. It is for cosmetic purpose. Barefoot walking possible. Shoe wear is optional. Squatting is possible. Flexible keel which is of rubber. Plantar or dorsiflexion is possible. Inversion or eversion is possible. Irregular surface walking possible. Next is safe foot. Safe foot, SAFE, is for solid angle flexible endoskeletal foot. That is safe foot. Above knee amputation is done from the musculotendinous junction of quadratus femoris. Below knee amputation is done from musculotendinous junction of gastrocnemius muscle. Next topic is Perthes disease or leg calve. Here the terms that we should remember is coxa plana osteochondritis of femoral head. This Perthes disease or leg calve is the idiopathic spontaneous osteonecrosis of head of femur, which is mainly due to blockade of venous outflow, which mainly causes arterial compression, and also there will be thick and distended veins which causes ischemia, and finally osteonecrosis can be seen. Incidence for this Perthes disease is 1 by 10,000. Male to female ratio is 5:1. Age group for Perthes disease is 4 to 9 years. Bilateral cases are about 10 to 12%. Perthes disease has an association most commonly with protein C and S deficiency, which is of factor V leading mutation. Other associations for this Perthes disease are sickle cell anemia, passive smoking, trauma, mutation in type 2 collagen. Pathology for Perthes disease is Waldenstrom classification or staging. That is, Stage 1 is ischemia, stage 2 revascularization and repair, stage 3 reossification. Revascularization and repair means there will be fragmentation of head, and stage 3 reossification consists of flat head, that is coxa plana, mushroom head, that is coxa magna, small head, that is coxa breva, and stage 4 is healed with residual deficit. Clinical spectrum of Perthes disease is, it is mainly seen in a child of 4 to 9 years of age. First clinical symptom is limping or antalgic gait. Here there will be pain in the hip region, which is mainly referred to groin, knee or thigh. So this is known as referred pain. Limitation of abduction, internal rotation will be seen at the hip. Obligatory external rotation while hip is flexed is seen here. So this is known as Cattrall sign. Diagnosis for Perthes disease is, on X-ray we can see gaze sign as well as sagging rope sign. Gaze sign is the V or U-shaped translucency in lateral portion of femoral head. Sagging rope sign is horizontal radio-opaque line in upper femoral metaphysis. Investigation of choice for Perthes disease is MRI more than bone scan. Differential diagnosis for Perthes disease is TB hip. In TB hip there is early acetabular involvement, and in Perthes disease there is late acetabular involvement. Management of Perthes disease is, it is a self-limiting condition. During the avascular phase, the management is like non-weight bearing, bed rest, abduction braces for containment of hip, skin traction to maintain joint space and to relieve the pain and also spasm. In repair or healed phase of Perthes disease, surgery should be done. On repair or healed phase, we can see gaze sign, metaphyseal cyst, lateral calcification, lateral subluxation of head, horizontal lying faces, and also these are the Cattrall at risk signs. One important sign is Caffey's sign, that is loss of sphericity of femoral head with subchondral fracture line mainly in weight bearing anterolateral part of femoral head. Next topic is slipped capital femoral epiphysis, SCFE. This is the capital femoral epiphysis is well seated inside acetabulum. It is the anterolateral disruption of neck which gives apparent posteromedial epiphyseal slip. Most common cause is idiopathic. Most common risk factor is obesity. Most common association is hypothyroidism. Other association are hypogonadism, GHXS, craniopharyngioma. Age group is in males about 13 to 17 years. In females 11 to 14 years. Male to female ratio is 2:1. Bilateral cases are about 30 to 35%. Pathogenesis is when there is an excess growth hormone, or if the patient is having hypergonadism, there will be physis of the proximal femoral head which causes hypertrophy and immature physis. During puberty, there will be a growth hormone surge which causes anterolateral disruption of physis and apparent posteromedial epiphyseal slip occurs. Clinical presentation is like patient will be short or fat or sexually immature of about 13 to 17-year-old. Clinically, there will be limping or antalgic gait or out-toeing gait. One important thing is Drennen sign. What is Drennen sign? That is obligatory external rotation at hip during hip flexion. Child sits in W posture. Restricted abduction and internal rotation is seen here. Diagnosis is by taking X-ray, CT as well as MRI. On X-ray we can see Tretoven sign. On CT we can see acute or chronic slip. MRI is the investigation of choice for diagnosis. Management is by categorizing this into mild, moderate and severe. Mild cases are about less than 33%. Moderate cases are about 33 to 50%. For the mild and moderate SCFE cases, we should do closed reduction in situ pinning. And severe cases are about more than 50%, and in severe cases we should do open reduction and also in situ pinning. This in situ pinning is done to prevent further recurrence. Surgery is always done bilaterally, otherwise length discrepancy occurs. Next topic is developmental dysplasia of hip, that is DDH. It is the idiopathic spontaneous subluxation or dislocation of head or femur from acetabulum. Before birth, DDH presents like oligohydramnios, packaging disorder, IUPD like congenital muscular torticollis, metatarsus adductus, and congenital knee dislocation. At birth, it is like malpresentation. Most common association is breech delivery with extended knees or legs. After birth, DDH is presented like postnatal theory, that is, if you carry baby with hips or knees extended, DDH can be seen. Incidence is 1 by 1000 live birth. Western more than Asians. Male to female ratio is 1:7. Bilateral cases are 20% of cases. In unilateral cases, left hip gets affected more than right hip. Overall sequence, left hip more than, bilateral cases more than right hip. Here 5 F's are there, that is female child, firstborn female of family, fair complexion, family history, faulty intrauterine position. Most common cause is idiopathic. Most common association is breech delivery with extended knees and legs. Pathogenesis is upward and lateral subluxation or dislocation of head or femur causes shortening. We can see inverted limbus sign, that is hypertrophied inverted infolded acetabular labrum, that is fibrocartilage, and also hypertrophied fibrofatty tissue, that is pulvinar, fills up the empty acetabulum. One more thing is hypertrophied ligamentum teres and transverse acetabular ligament can be seen here. One important feature when talking about DDH is hourglass constriction of capsule. This is one important thing. Clinical presentation is like first risk factor should be identified. We can see wide perineum and also asymmetrical skin crease on thigh and gluteal folds. In a child of age less than 3 months, there are two tests, that is ortolani's test and Barlow's test. Ortolani's test shows dislocated hip, and in Barlow's test we can see dislocatable hip. And one another sign is Ali's sign. Ali's sign or Galeazzi's test shows shortening. In walking age group, that is unilateral DDH shows Trendelenburg or abductor or lurching gait. In bilateral DDH, we can see duck waddling gait. Next is diagnosis of DDH is by taking X-ray, USG and MRI. On X-ray, we can see broken Shenton line on upper and outer Perkins quadrant. Next is USG. USG is the investigation of choice for screening of DDH. According to American Academy of Pediatrics, routine USG screening is done for DDH at 4 to 6 weeks in female. Female infants with positive family history and breech delivery, USG is done according to Graf's classification. Next is MRI. MRI is the investigation of choice for diagnosis of DDH in overall age more than 6 months according to Kashiwagi classification. Age-wise management for DDH is, if the patient is less than 6 months, closed reduction immobilization by Pollock harness splint as well as von Rosen splint is done. If age group is in between 6 to 18 months, we should do open reduction using Smith-Petteran's anterior iliofemoral approach by putting bikini incision, and then immobilization should be done with bachelor's cast. If patient is more than 18 months, that is more than 1.5 years, acetabular reconstruction surgery should be done. Here most common surgery performed is Salter's osteotomy. Best result is received by Pemberton's osteotomy, and next is salvage surgery, which is a shelf procedure. Next topic is Seudeck's osteoneurodystrophy. It is a reflex sympathetic dystrophy. It is also known as complex regional pain syndrome. Stage 1 is bony or soft tissue injury. Stage 2 is nerve injury. Seudeck's osteoneurodystrophy is a rare or delayed complication of Colles fracture. Here we can see severe pain or intense pain out of proportion. Swelling present, stiffness present, shiny and stretched skin is seen here. Hyperaesthesia present, uninhibited oversympathetic stimulation is present. On X-ray, osteopenia is seen. Management is by using sympatholytics, muscle relaxants like amitriptyline, NSAIDs, sympathetic ganglion blockade, surgical sympathectomy, and prophylactic vitamin C is used. Next topic is Colles fracture. Extra-articular fracture of distal end of radius with dorsal or posterior displacement of distal fragment is Colles fracture. In this Colles fracture, we can see dinner fork deformity. Displacements of Colles fracture include DILS, that is dorsal, impaction, lateral, supination. Complications of Colles fracture include most commonly finger stiffness, second most commonly malunion, that is dinner fork deformity or pseudo-Madelung, carpal instability, carpal tunnel, rupture of extensor pollicis longus, post-traumatic shoulder stiffness, pseudex osteoneurodystrophy, that is reflex sympathetic dystrophy. These all are the complications of Colles fracture. Management is by using Colles cast or handshake cast. Here the levels of degree, that is degree of Colles cast use is 15-degree pronation, 15-degree palmar flexion, 15-degree ulnar deviation. Next is Holstein-Lewis fracture. It is an oblique displaced fracture of shaft of humerus at junction of upper 2/3 and lower 1/3 of shaft with radial nerve palsy. Next topic is pulled elbow or nursemaid's elbow. Here distal subluxation of head of radius which leads to widening of radiocapitellar groove, and the annular or orbicular ligament gets stuck in widened radiocapitellar groove. Child locks elbow in extension and doesn't allow anyone to touch, that is apprehension test is positive. Management for pulled elbow is closed reduction. Next is Montague's fracture. It is the fracture of proximal 1/3 of ulnar shaft and radial head dislocation. Most common nerve injured is posterior interosseous nerve. Fracture of necessity is orifice compulsory. Next is Galeazzi's fracture or reverse Montague's fracture or Piedmont fracture. It is the fracture shaft of radius at junction of middle and distal 1/3 of shaft with distal radio-ulnar joint disruption. This is a fracture of necessity, so orifice compulsory, that is open reduction and internal fixation is compulsory. 3 times more common than Montague's fracture. Next topic is reverse Galeazzi's fracture. It is the fracture of shaft of ulna at the junction of middle and distal 1/3 with distal radio-ulnar joint disruption. Next is nightstick fracture. Nightstick fracture is the isolated fracture of shaft of ulna. Mechanism of injury is direct trauma to forearm while in a defensive stance. Next is green stick fracture. This is seen in children. Here the unicortical fracture of forearm bone, mainly radius and ulna with concavo-convex deformity is seen. Next is Barton's fracture. It is the intra-articular fracture of distal end of radius with radiocarpal joint subluxation. Next is Choffer's fracture or Hutchinson's fracture or backfire fracture. It is the intra-articular fracture of distal end of radius with fracture radial styloid process. Here radiocarpal joint is normal. Next is Smith fracture or reverse Colles fracture. That is extra-articular fracture of distal end of radius with volar or anterior displacement of distal fragment. Most common complication is malunion, that is garden spade deformity. Next is Hotchkiss terrible triad. It is fracture head radius, fracture coronoid process of ulna, and posterior elbow subluxation or dislocation. Salter-Harris classification consists of 1 to 5. First one is no obvious fracture line, minor to major physeal slip. Example, slipped capital femoral epiphysis. Second classification is extra-articular injury, triangular metaphyseal bone fragment seen. Here Thurston Holland sign is present. Example, supracondylar fracture humerus. Classification 3 is intra-articular injury, physeal fracture line extending into epiphysis. Example, lower end of tibia fracture. Fourth classification is the second most common type. It is the intra-articular injury. Here rotation of distal fragment happens and the articular surface becomes non-articular and vice versa. Fifth classification is worst prognosis. It is of least common type. This is due to the fall from height. Initial x-rays are normal. Partial or complete facial crushing injury is seen. Investigation of choice here is MRI. Complications are growth disappears and limb length deformities are seen here. Next topic is fracture of distal humerus. First is supracondylar fracture humerus. Most common fracture due to fall onto an outstretched hand, that is FOOSH. Foosh. Most common fracture due to foosh in children is supracondylar fracture humerus. It is also the most common fracture in children around elbow. Supracondylar fracture humerus comes under Salter-Harris type 2. It is an extra-articular fracture. 3. Bony point relationship is normal here. Most common mode of injury is FOOSH, that is fallen onto an outstretched hand. Mechanism of injury in supracondylar fracture humerus is hyperextension. Types of supracondylar fracture humerus is 96% cases are extension, that is posteromedial extension more than posterolateral extension. Next type is flexion, that is 4% of cases are flexion type, which consists of volar as well as anterior. Next is Gartland's classification. Gartland's classification 1 is minimally displaced, undisplaced or impacted fracture. Here the x-rays are normal. Management is above elbow cast or POB slab for 3 weeks. Classification 2 is unicortical angulation present, no displacement. Here management is closed reduction plus above elbow cast or POP slab is put. Classification 3 is complete fracture, bicortical fracture, completely displaced fracture, and here the management is closed reduction plus K-wear fixation. Complications of supracondylar fracture humerus include most commonly malunion, that is cubitus varus or gunstock deformity, neurological injuries, vascular injury, most commonly brachial artery, compartment syndrome, Volkmann's ischemic contracture, myositis ossificans. Next topic is cubitus varus. It is gunstock deformity. Malunited supracondylar fracture humerus is most commonly complicated this way. This occurs due to uncorrected medial tilt. This is a static deformity and also cosmetic deformity. Management of cubitus varus is French osteotomy and also modified French osteotomy. In French osteotomy, incision is posterior midline, and in modified French osteotomy, incision is posterolateral incision. In French osteotomy, triceps detachment is like whole triceps is detached, and in modified French osteotomy, lateral triceps is detached. In French osteotomy, ulnar nerve is explored, that is, it is kept safe, and in modified French osteotomy, ulnar nerve is not explored. In French osteotomy, medial cortex is broken. In modified French osteotomy, medial cortex is intact. Next is neurological injuries in supracondylar fracture humerus. It is usually neuropraxia, recovers transiently. Most common nerve injured in supracondylar fracture humerus overall is anterior introitious nerve, branch of median nerve. In posterolateral displacement also, anterior introitious branch of median nerve gets injured. In posteromedial displacement of supracondylar fracture humerus, radial nerve gets injured. And in anterior or volar displacement of supracondylar fracture humerus, ulnar nerve gets injured. Next topic is compartment syndrome. Etiology of compartment syndrome is increased content like bone, muscle or vessel, and also reduced size. Reduced size consists of post-burn contracture as well as tight circumferential cast or POP dressings. Most common content is bone, that is, it is most common fracture happens in the bone. In children, supracondylar fracture humerus, and in adults, fracture proximal tibia. In these cases, bone is affected And if muscle is the content in compartment syndrome, it is mainly due to the crush or traumatic rhabdomyolysis. If vessel is the content, it is mainly due to vascular injury. Clinical feature is it consists of 7P. First P is pain, second is pallor, paresthesia, paralysis, pulselessness, increased pressure. So pain is the first symptom, and first sign is pain on passive stretching, which is known as stretch test positive. This is the most diagnostic or sensitive sign. Management for compartment syndrome is fasciotomy. One important thing I missed is in clinical features we said that there will be increased pressure. So normal pressure is 6 to 12 millimeter mercury. When the pressure is more than or equal to 30 mmHg, it is a diagnostic of compartment syndrome. And another thing is pulselessness. Pulselessness is a late feature and it is not a diagnostic criteria. Next is some interesting facts, that is most common fractures. This is the heading. So starting with most common fracture overall is seen in clavicle. Most common fracture in newborn is seen in clavicle. Most common fracture seen in delivery time is clavicle. Most common fracture during a difficult delivery is humerus. Most common fracture in children is green stick fracture, where radius gets more affected than ulna. Most common fracture in children around elbow is supracondylar fracture humerus. Most common carpal bone which gets fractured is scaphoid. Most common carpal bone which gets dislocated is lunate. Most common tarsal bone which gets fractured is calcaneum. Most common tarsal bone which gets dislocated is talus. Most common bone which causes open fracture is tibia. Most common bone which causes pathological fracture is vertebral body, that is T12. Most common bone which causes stress fracture is tibia more than shaft of second metatarsal, which is known as march fracture. Most common joint to undergo dislocation is shoulder. Least common joint to undergo dislocation is knee. Most common joint to undergo recurrent dislocation is shoulder. Least common joint to undergo recurrent dislocation is ankle. Most common tendon to undergo injury is supraspinatus more than tendoachillis. Most common ligament to undergo sprain is ATFL, that is anterior talofibular ligament. Strongest ligament is Biglows ligament and also iliofemoral ligament. Most common peripheral nerve injury is seen in radial nerve. Best prognosis for peripheral nerve injury is radial nerve. Worst prognosis for peripheral nerve injury is for ulnar nerve. Worst prognosis despite surgical repair is sciatic nerve. Most common fracture due to fall on outstretched hand in children is supracondylar fracture humerus. Most common fracture due to fall on outstretched hand in adult is fracture scaphoid. Most common fracture due to fall on outstretched hand in elderly is Colles fracture. Most common arterial injury is seen in popliteal artery. Largest carpal bone is capitate. First carpal bone to ossify is capitate. Most common joint to undergo dislocation in children is in elbow. Least common carpal bone fractured is trapezoid. Most centrally located carpal bone is capitate. Most common tarsal bone to develop stress fracture is navicular bone. Last carpal bone to ossify is pisiform. Next topic is shoulder dislocation. Classification of shoulder dislocation includes anterior shoulder dislocation, posterior shoulder dislocation, and also inferior shoulder dislocation. Most common subtype is anterior shoulder dislocation, that is 95 to 98% of shoulder dislocation cases are anterior shoulder dislocation. Mechanism of injury is abduction and external rotation. Here this shoulder dislocation is very painful, and example is vigorous throwing of ball can cause anterior shoulder dislocation. Next type is posterior shoulder dislocation. 3 to 4% of shoulder dislocation are posterior shoulder dislocation. Mechanism of injury is adduction, internal rotation. Example is epilepsy, electric shock. These can cause posterior shoulder dislocation. Pain of posterior shoulder dislocation is Patient presents with minimally painful or minimally painless condition. Next is inferior shoulder dislocation. 1 to 2% of shoulder dislocation cases are inferior. Mechanism of injury is hyperabduction. Example is patient locks arm by side of the head, that is salute posture. This can cause inferior shoulder dislocation. X-ray of posterior shoulder dislocation shows electric bulb sign and also empty glenoid sign. Clinical tests for anterior shoulder dislocation includes Dugas test, Galloway's test, and also Hamilton ruler test. Dugas test is inability to touch the opposite shoulder. Hamilton ruler test is ruler touches both acromion and lateral condyle simultaneously. Galloway's test is per axillary palpation of head of humerus. Complications of shoulder dislocation include most commonly overall is recurrent dislocation. Immediate complication is injury to circumflex branch of axillary nerve. Delayed complication is recurrence. Management of shoulder dislocation is closed reduction. Method of closed reduction includes Hippocratic method, Stimson's gravity technique, modified Kocher's technique. In modified Kocher's technique, what we do is TEAI, that is traction, external rotation, adduction, internal rotation. Next topic is fracture clavicle. It is the most common fracture overall and also in a newborn and also most common fracture during delivery. Most common site for fracture clavicle is junction of medial 2/3 and lateral 1/3. Most common complication for fracture clavicle is malunion. Most serious complication of fracture clavicle is subclavian vessel injury and also brachial plexus injury. Management of fracture clavicle is conservative management by using figure of 8 bandage and also clavicular brace. Other mode of treatment is surgery. Indications of surgery for fracture clavicle is neurovascular injury, fracture at lateral end of clavicle with acromioclavicular joint disruption, cosmetic defect, floating shoulder. Floating shoulder is seen in glenoid neck fracture or shaft of the clavicle fracture. Next topic is osteoporosis. It is a porous bone disease. Most common risk factor is post-menopause. Most common cause is senile or aging. Drugs causing osteoporosis is corticosteroids, anticonvulsants, thyroxine, GnRH analog. Secondary osteoporosis can cause excess osteoblastic bone resorption more than normal osteoblastic bone formation. Clinical features for osteoporosis include perimenopausal female, mostly asymptomatic. Earliest symptom is back pain. Most common complication is pathological fracture in vertebral body of T12. Biochemical analysis includes serum calcium will be normal, serum phosphate will be normal, serum alkaline phosphate will be normal. Bone marker for resorption are serum and urine levels of type 1 collagen degradation products like proline, hydroxyproline, deoxypyridinoline, N-telopeptide, C-telopeptide. These all should be checked. On taking X-ray spine, we can say fish mouth spine. DEXA scan, that is dual energy X-ray absorptiometry, that is DEXA scan, which is the gold standard investigation. WHO defines osteoporosis as T-score less than or equal to -2.5. Management of osteoporosis is by taking drugs like bisphosphonates, which is the drug of choice. Next is denosumab. Surgery is by doing vertebroplasty or kyphoplasty. Kyphoplasty is better here. Percutaneous injection of bone cement in vertebral body is done. Two important things to be remembered is fish mouth spine is seen in osteomalacia more than osteoporosis. Rugger jersey spine is seen in renal osteodystrophy more than osteopetrosis. Next topic is osteomalacia. It is also known as malakosteon osteopathy or hunger war. It is a qualitative bone defect. Causes of osteomalacia includes decreased dietary intake of calcium, poor GI absorption, poor renal tubular reabsorption. This all leads to deficient calcium, which leads to lack of properly formed osteon. There will be compensatory increase in osteoblastic activity and there will be increased osteoid. Here the osteoid by osteon is more than 1. Clinical feature for osteomalacia is patient will be young female of about 15 to 40 year of age, presents with bone pain, polyarthralgia, proximal myopathy. Most commonly spine is affected. Biochemical analysis include serum calcium will be reduced, serum phosphate will be reduced, serum alkaline phosphate will be increased. Bone markers of formation include serum levels of type 1 collagen like osteocalcin, osteonectin, osteopontin. On X-ray, fish mouth spine can be seen. On pelvis, Luso's zone can be seen. No displacements or no callus is formed. Management of osteomalacia include diet rich in calcium like milk and green leafy vegetables should be taken. Vitamin D supplements like cod or fish oil should be taken. Adequate sunlight is also needed for osteomalacia. Next topic is Paget's disease or osteitis deformans. Excess osteoblastic bone formation with excess osteoclastic bone resorption is seen here. Most common bone affected is pelvis. Age group is 4th to 5th decade. Asymptomatic in most cases. First most common symptom is back pain. Diagnosis includes elevated alkaline phosphatase. Bone biopsy shows mosaic pattern, which is the gold standard investigation. On X-ray, we can see osteoporosis circumscripta, cotton wool skull, Tam O'Shanter sign, flame sign or blade of grass sign or advancing bed sign, picture frame spine, brim sign which shows thick and sclerotic iliopectineal line. Most common pre-malignant lesion for secondary osteosarcoma is Paget's disease or osteitis deformans. Drug of choice for Paget's disease is bisphosphonates. Next topic is osteopetrosis or marble bone disease or Albert-Schomburg disease. It is the defect in carbonic anhydrase 2 proton pump which causes defective osteoclastic bone resorption. There will be excessive deposition of normal osteoblastic bone formation which causes thick or dense or sclerotic bone. Clinical feature of osteopetrosis is seen in infants. Here bone marrow failure which causes pancytopenia. Recurrent infection is present here. Osteomyelitis of mandible, hepatosplenomegaly and recurrent hemorrhage is seen in this case. On taking X-ray of long bone, we can see endobone sign as well as Erlenmeyer flask deformity. On taking X-ray spine, Ruger-Jersey spine can be seen. Ruger-Jersey spine is seen in renal osteodystrophy more than osteopetrosis. Next topic is osteogenesis imperfecta. It is also known as brittle bone disease or fragilitis osseum or Vrolik-Lobstein disease. This is due to COL1A1 gene mutation which causes glycine substitution. There is no cross-linkage in type 1 collagen, no tensile strength in bone, and also this disease is mainly due to type 1 collagen synthesis defect. Clinical spectrum is this disease is mainly seen in preschool child with multiple long bone fracture, no history of trauma, blue sclera present, and also poor and delayed dentition is seen here. On X-ray, diaphyseal deformities are present. Different stages of healing are also seen. Management of brittle bone disease or osteogenesis imperfecta includes braces to prevent further deformity, bisphosphonates, corrective osteotomy by realignment osteotomy, Sofield-Miller surgery, internal fixation with telescopy nail as well as Bailey and Dubois rods. Differential diagnoses include battered baby syndrome or Caffey syndrome. How can we differentiate battered baby syndrome or Caffey syndrome from osteogenesis imperfecta? Answer is, in battered baby syndrome or Caffey syndrome, the patient will be a preschool child, multiple long bone fractures are seen, signs of violence are present. On X-ray, metaphyseal fractures on distal radius or ulna present. Here, coronar or bucket handle fracture is also seen. Next topic is about compression neuropathy. Carpal tunnel syndrome causes compression neuropathy by median nerve at rest. Guyon's canal syndrome causes compression neuropathy by ulnar nerve at rest. This is also known as pisohamate canal. Cubital tunnel syndrome causes compression neuropathy by ulnar nerve behind the medial epicondyle. Radial tunnel syndrome causes compression neuropathy by posterior interosseous nerve. Pronator syndrome causes compression neuropathy by median nerve between two heads of pronator teres. Kilon-Nevin syndrome causes compression neuropathy by anterior interosseous nerve, which is a motor branch of median nerve. Piriformis syndrome causes compression neuropathy by sciatic nerve compression. Neuralgia paresthetica causes compression neuropathy by lateral cutaneous nerve of thigh. Choralgia paresthetica causes compression neuropathy by superior sensory branch of radial nerve. Morton's metatarsalgia causes compression neuropathy by interdigital plantar nerve compression, which causes excruciating pain on squatting. Next is notalgia paresthetica causes compression neuropathy by superior sensory neuropathy in infrascapular area. Here we can see pruritus as well as dysesthesia. Treatment is pregabalin. Next topic is Seddon's classification of peripheral nerve injury. It consists of neuropraxia, axonotmesis, neurotmesis. Neuropraxia, it is the physiological conduction block. Anatomy, axon and nerve sheath will be normal. There will be transient demyelination. Next is axonotmesis. Partial anatomical conduction block is seen here. Axonal disruption is seen. Sheath will be normal. Surgery should be done. Next is neurotmesis. Complete anatomical conduction block present. Axon and sheath both are disrupted. Surgery is compulsory. Next is red flag signs of backache. Red flag signs are age less than 20 years, age more than 50 years, cachexia, constant pain, saddle anesthesia, history of malignancy, history of steroid use, IV drug abuse. Next is yellow flag signs of backache. Anhedonia, low mood, poor job satisfaction, high functional limitation more than 1 month, psychological disturbance, social isolation, alcohol dependence. Next topic is prolapse intervertebral disc. Most common level is L4, L5 more than, L5, S1 more than, C5, C6 more than, C6, C7. MRI based staging for prolapse intervertebral disc is stage 1 disc degeneration or disc bulge, stage 2 disc protrusion, stage 3 disc herniation or extrusion, stage 4 disc sequestration. Types of PIVD are, it depends upon the direction of prolapse. First thing is posterolateral or paracentral, second type is far lateral or foraminal. Posterolateral or paracentral type of PIVD is at low level of nerve root. Far lateral or foraminal type of PIVD is at the upper level of nerve root. Clinical test for prolapse intervertebral disc are straight leg rise test, Bragard sign, Lesigue sign, bowstring sign of MCNAB. Investigation of choice include MRI. Management for prolapse intervertebral disc include conservative management, that is for acute pain, bed rest, NSAID and muscle relaxant. Intermittent lumbar traction, superficial heat, deep heat should be done for the prolapse intervertebral disc. Superficial heat is given by hot packs, infrared therapy. Deep heat should be given by shortwave diathermy as well as ultrasonic therapy. Next mode of treatment is using TENS for radicular pain. TENS means transcutaneous electrical nerve stimulation. For chronic pain, epidural steroids, spine extension exercises, lumbar belts or corsets should be used. Indication for surgery is absolute indication include progressive neurological deficit or cauda equina syndrome. Relative indication for surgery includes severe sciatic pain despite 6 weeks of conservative treatment, recurrent incapacitating sciatica attacks more than 3 per year. Surgery is by doing decompression with discectomy. Surgical approaches include laminectomy, hemilaminectomy, laminotomy or fenestration surgery, which is the surgery of choice via microscope, Next is laminoplasty. Laminoplasty was done in cervical canal stenosis. In this case, only laminectomy, hemilaminectomy, laminotomy, these three are the surgical approaches. Mainly, laminotomy or fenestration surgery is the best choice. Next is about myotomes. C5 myotome is at deltoid, C6 myotome is at wrist extensors, C7 at wrist flexors or elbow flexors, C8 is finger flexors, T1 finger abductors, L1, L2 myotomes are hip flexors, that is iliopsoas, L3 is knee extensors or quadriceps, L4 is ankle dorsiflexors, that is tibialis anterior, L5 is extensor hallucis longus, S1 is ankle plantar flexors, that is gastrosoleus. Next is reflexes. C5 reflex is biceps, C6 reflex is supinator, that is brachioradialis, C7 reflex is at triceps, L3 L4 reflex is at quadriceps, that is knee reflexes, L5 S1 is plantar reflex, that is femoris, S1 S2 reflex is ankle reflex, that is gastrosoleus. Next topic is Klippel-Feil syndrome. It is also known as dystrophia brevicollis congenita. This is mainly due to bony pathology or segmentation failure. Here congenital fusion of cervical vertebra occurs. This case is mainly seen in a child. There is a triad of Klippel-Feil syndrome, that is short webbed neck, low posterior hairline, reduced range of movement at neck. The child will be of short stature. Most common association is Sprengel's deformity. Other associations include congenital heart defect, ocular anomalies, and also genitourinary tract abnormalities. Management is to prevent complications like cervicothoracic scoliosis, and also we should avoid collision sports. Next topic is congenital muscular torticollis. It is also known as Reinecke. It is of muscular pathology. Here overcontraction of sternocleidomastoid muscle occurs and there will be fibromatosis of sternocleidomastoid muscle. Palpable neck mass is seen at birth within 4 to 6 weeks after birth. Congenital muscular torticollis has an association with developmental dysplasia of hip and also metatarsus adductus. In this case, contracted sternocleidomastoid muscle is present at the junction of upper 2/3 to lower 1/3, and also right side gets affected more than the left side. And in 90 to 95% of the patients, this gets relieved by doing regular stretching exercise. In 5 to 10% of patients, surgical release of muscle is done. This is only done after 1 year of age. Complication of congenital muscular torticollis include plagiocephaly, that is asymmetrical development of skull and face, and next is ipsilateral head tilt, contralateral chin lift deformity which shows cock robin appearance. Next topic is spondylolisthesis. It is the slippage of one vertebral body over another vertebral body. Most common level is L5 S1 more than L4 L5. Most common nerve root irritated is L5. Types of spondylolisthesis includes isthmic or lytic, dysplastic, degenerative, traumatic, pathological. First type is isthmic or lytic. It is the most common type of spondylolisthesis. Here there is a defect in pars interarticularis. Mainly during sports activity there will be fatigue fracture of pars interarticularis, and also there is congenitally weak pars interarticularis in this case. Next is dysplastic type of spondylolisthesis. It is a rare type. It is a congenital type. There is no defect or no fracture in pars interarticularis. There is a defect in the formation of first sacral arch and superior facets of S1. Neurodeficit is more in this type compared to isthmic type. Next is listhetic crisis. What is it? It is an acute onset of sudden pain with rigidity in paraspinal muscle with functional or spastic scoliosis. Third type is degenerative. It is the second most common type more than isthmic. Most common level affected is L4, L5. It is seen in females of more than 50 years. Next is traumatic type. Traumatic type, there is fracture in an area other than pars interarticularis which causes a slip. Pathological type is it is generalized or localized bone pathology which causes fracture of pars interarticularis. Clinical spectrum is like asymptomatic initially, incidental diagnosis. First symptom is backache. In pathological type itself, while talking about the backache, if the patient is having low back discomfort, it is of degenerative type, and if the patient is having acute and sudden pain, it is of dysplastic type. Patient will be having radiculopathy. Diagnosis is by taking X-ray. On X-ray on oblique view of L5 spine, there will be a defect in pars interarticularis, which shows a break in neck of Scotty Terrier dog shadow. Here the sign is known as B-headed Scotty Terrier sign or Scotty dog wearing a collar sign. Actually, Scotty dog terrier shadow is a normal finding in oblique X-rays of L5 spine. On taking X-ray on AP view, we can see inverted Napoleon hat sign, which is least useful diagnostic method. This inverted Napoleon hat sign is due to superimposition of sacrum and L5. X-ray is also taken with flexion and extension views to see spinal stability. Next is management of spondylolisthesis. It is based on Meierding's classification or staging. Here the anteroposterior diameter of superior surface of lower vertebral body is divided into quarters. That is for first and second quarters. That is first one is less than 25% and second one is 25 to 50%. For first and second quarters, conservative management is given. For the third quarter, that means 50 to 75% of cases, and fourth quarter, that is more than 75% of cases, we do surgery. That is surgery is done when there is a progressive neurological deficit or canal stenosis or refractory pain. Next is the term spondylitis is paraspinal muscle spasm. The term spondylolysis is fracture of pedicle or pars interarticularis. The term spondylolisthesis is slippage of one vertebral body over another vertebral body. Most common mode of spinal trauma in developing nation is fall from height, and the most common mode of spinal trauma in developed nation is road traffic accident. Most common mechanism of spinal trauma is flexion distraction more than flexion. Worst mechanism of spinal trauma is translation more than flexion rotation. Spinal canal is widest at C2 level. Vertebra which is always constant in number is cervical. Most variable in number is coccygeal vertebra. Most common site of spinal trauma is in cervical spine. Most common site of spinal fracture is lower thoracic spine. Most common site of spinal cord injury is cervical spine. Most common site of peripheral nerve injury is radial nerve. Peripheral nerve injury with best prognosis is radial nerve. Peripheral nerve injury with worst prognosis is ulnar nerve. Peripheral nerve injury with worst prognosis despite of surgical repair is sciatic nerve. Most common site of skull bone fracture is temporal. Most common site of facial bone fracture is nasal more than zygomatic. Most common site of mandible fracture is neck of condyle. Next topic is scivora, that is SCIWORA. Scivora is for spinal cord injury without radiological abnormality. This is seen in children less than 8 years. Initial X-ray shows normal. Presentation is like it is neurodeficit and also no spinal reflex is seen. Investigation of choice is MRI upper cervical spine should be taken. Next is undertaker fracture. It is a postmortem finding which is due to careless handling of dead body by undertaker. Here the fracture or subluxation of lower cervical spine with C6 to C7 intervertebral disc disruption or tear. Next topic is chance fracture, which is also known as seatbelt injury or jackknife injury. Here head-on collision during road traffic accident happens. Mechanism is flexion, distraction as well as rotation. Horizontal fracture line transversing the vertebral body through all three columns happens here. Level is T12 to L2. In 50% of the patients, concomitant intra-abdominal injury is seen. Next is Jefferson's fracture. It is the burst fracture of C1 ring, that is atlas, involves both anterior and posterior rim. In 85% of the patients, there is no neurological deficit. Undisplaced fracture is known as collar and displaced fracture is halo vest. Next topic is hangman's fracture. Mechanism is hyperextension followed by distraction. Spondylolysis, that is fracture of pars interarticularis or pedicle of C2, that is axis, with spondylolisthesis of C2 over C3 with C2 C3 IV disc disruption. Next is Clay-Chauvel's fracture. It is the avulsion fracture of tip of spinous process of C7 more than T1 seen in the laborers who do heavy weightlifting with arms extended. Next topic is scaphoid fracture. Most common carpal bone fracture is scaphoid fracture. It is mainly due to fall on outstretched hand in adults. Here distal to proximal retrograde blood flow occurs. Most common site is waist of the scaphoid bone. Clinical feature is tenderness or swelling in anatomical snuff box is seen. On X-ray, PA view in 15-degree ulnar deviation present. Most common complication is non-union. Second most common complication is avascular necrosis of proximal pole. Management is for undisplaced fracture, scaphoid cast or glass holding cast is put. For displaced fracture, ORIF with Herbert screw is placed. Next is Bennett's fracture. It is intra-articular fracture of first metacarpal. It is more displaced. Next is Rolando's fracture. It is intra-articular fracture of first metacarpal. T or Y-shaped comminuted fracture is seen, less displaced. Next is Boxer's fracture. It is fracture neck of fifth metacarpal bone. It is the most common metacarpal fracture. Next is mallet finger. It is an avulsion of extensor tendon from dorsal aspect of base of distal phalanx at distal interphalangeal joint which shows flexion deformity. Next is jersey finger. It is an avulsion of flexor digitorum profundus from volar aspect of base of distal phalanx. Next is gamekeeper's or skier's thumb. It is an avulsion of ulnar collateral ligament from first metacarpophalangeal joint. Next topic is Madelung deformity. It is a bilateral pediatric congenital deformity. Here growth retardation of ulnar aspect of distal end of radial physis happens. There will be thick prominent distal ulnar variance present. Dinner fork deformity can be seen here. Management is osteotomy by Darac's procedure. Last topic is test in orthopedics. First of all, pen test. Pen test is done to check abductor pollicis brevis muscle. The nerve here is median nerve. Card test, palmar introshi muscle, ulnar nerve. Igavens test, dorsal introshi muscle, ulnar nerve. Book test or Froment sign, adductor pollicis muscle, ulnar nerve. Phalen's test, carpal tunnel syndrome. Durkan's test, carpal tunnel syndrome. Cosen's test, tennis elbow, lateral epicondylitis. Yergason's test, bicipital tendinitis. Lift-off test to check subscapularis muscle. Dugas test, Callaway's test, Hamilton roller test, these all are done for anterior shoulder dislocation. Finkelstein's test is done for decurvain tenosynovitis. Allen's test to check the patency of superior palmar arch. Edson's test is done for thoracic outlet syndrome. Thomas test is done to check flexion deformity at hip. Ober's test is done to check iliotibial band contracture. Simon-Thompson test is done for tendo-Achilles tear.